Thank you so much, Dennis and Dr. Del Rio, Dr. Leota. On behalf of our team at Health Connect South, thank you very much for being featured speakers this year discussing understanding the future of COVID-19. We are honored for both of your time. I'd like to just do some quick introductions and turn it over to both of you for this fireside chat, if you will. Dr. Carlos Del Rio is the Distinguished Professor of Medicine in the Division of Infectious Disease at Emory University School of Medicine. He's also the Executive Associate Dean for Emory at Grady. He is the Professor of both Global Health and Epidemiology at the Rollins School of Public Health, the Co-Director of the Emory Center for AIDS Research. And Dr. Del Rio has also authored and co-authored 30 book chapters and over 350 scientific papers. In 2013, Dr. Del Rio was elected to the National Academy of Medicine, and in 2020 was elected as Foreign Secretary of the National Academy of Medicine. Dr. Del Rio has been absolutely one of the leading voices on the COVID-19 response and has served an incredible public service to so many people looking for more information on this pandemic and what they do and what they need to do. And so Dr. Del Rio, thank you very much for being part of our panel. I'd also like to take this opportunity to introduce Dr. Dennis Leota, who is the Samuel Candler Dobbs Professor of Chemistry at Emory University. In addition, Dr. Leota is the Executive Director of the Emory Institute for Drug Development. He's also the Associate Director of the Emory Center for AIDS Research. He has co-authored approximately 300 scientific papers and is an inventor on approximately 100 US patents. Dr. Leota is also the founder of Drive, a nonprofit drug development company focused on the design and development of small molecule drugs for the delivery of a variety of viral infections, including MK-4482, which is currently in phase 2 clinical trials for treating COVID-19 infections, which I know everyone watching this is very excited and hopeful for its progress and hopefully widespread adoption. With that, I'd like to turn this over to Dr. Del Rio and Dr. Leota for their session. And thank you both very, very much for joining us today.
Thank you, Russ. Carlos, let's start off with some general questions about COVID-19. Despite mixed reports about its utility, convalescent plasma treatment has recently been granted emergency use authorization status by the FDA. Can you tell everyone what convalescent plasma treatment involves and how does this differ from antibody therapies being developed at several pharmaceutical and biotech companies?
So convalescent plasma, Dennis, is taking plasma from somebody who's recovered from the infection, i.e. they're convalescing. And then if that person has levels of antibodies high enough in their blood, then to use that plasma and give it to somebody who has the infection as a way of treatment. There are a couple of issues that need to be taken into consideration here. Number one, not all convalescent plasma is created the same. So we need to be sure that those plasma has high levels of antibodies against the virus and preferably high levels of neutralizing antibodies. And not all places are testing. So just because somebody's recovered from the infection doesn't mean they have high levels of antibodies. We know from several studies that people who are men who are over the age of 60 and who've been in the hospital sick, critically ill with COVID and recovered have much higher levels of antibodies than, say, somebody in their 20s who had a very mild illness, almost asymptomatic, let's say, or mildly symptomatic. They don't even need to be in the hospital. Those people have much lower antibody levels. But part of the problem is that the antibody tests are not standardized. So even deciding which is the right antibody, the right plasma to use is complicated. Number two is that assuming you have good plasma with high levels of neutralizing antibodies, the available evidence we have today is that it makes a difference if you give it very early on in infection. So ideally in the first 3 days after the onset of symptoms. And most of us know that very few people get seen or get into the hospital before 3 days of onset of symptoms. So plasma then offers limited use when you have somebody who's already 5-10 days into their illness and pretty ill. So there's still studies going on. I think plasma has a role, but I think the role is not as much as we would like it to be. I think that I'm much more excited about the monoclonal antibodies. I think monoclonal antibodies are essentially taking those antibodies in plasma, but really producing them at big scale. Is taking, you know, your bicycle and turning them into a motorcycle. You're really going at a much higher speed, much higher levels. And I'm more excited about monoclonal antibodies and therapy. And again, not only for treatment, but also for prevention. We're about to start a study in which where there are two important studies happening with monoclonal antibodies through the CoVPN network. One of them is for people who have been diagnosed with COVID and who are not sick enough to be in the hospital, can we give monoclonal antibody infusion to prevent them from developing disease and getting better? And number two, can we give it prophylactically? In other words, if somebody's found to be infected, can we go to their house, test the family members, and those that are negative, give them the antibody as a way to prevent them from getting infected, very much like a vaccine would work. And I think monoclonal antibodies really have a significant future in the management of this infection.
Great, thank you. Early in the pandemic, it appeared that children didn't develop severe symptoms seen in adults, and they very rarely died. It even seemed that they didn't contract the disease at the same rate as adults did. However, new data suggests this is not the case. Can you give us a brief overview about the current understanding of the consequences of COVID-19 infections in children?
Yeah, so it's really interesting, right? Initially in the epidemic, I even wrote a paper said people under 18 rarely get infected. I think still the infection rate is much lower in young children, especially under the age of 10. And the possibility of them getting severe disease is much, much lower than adults. We know that the older you get, I think one mistake in this epidemic saying 65 is when you get sick. No, anybody can get sick. It gets higher as you get older, but it's not one point where all of a sudden before that is nothing and above that is everything. It happens at all stages. Everybody can get sick. It just increases significantly the older you get. But having said that, children can still get sick, can still get very ill, and can still die, and they can still transmit. So we shouldn't say, oh, children are out of the woods. Children can still be a problem. What may be different, and what's still trying to understand well, for example, in influenza, children are a major source of transmission. In COVID, it doesn't appear to be the case, but it may be, Dennis, that we have kept the children really isolated, locked down at home, and it's going to change once they start going to schools. So I think that's part, we changed the epidemiology by very early sort of going into those lockdowns and keeping children at home.
So to follow up on something you just briefly alluded to, we know now that younger children and teenagers shouldn't be lumped together when it comes to the way that we handle their COVID infections. Teens seem to shed virus at about the same rates as adults. But as you said, children, they might even have high levels of virus, but it's not clear why they don't develop symptoms as often as adults do. So what are the implications of this regarding in-person versus virtual schooling at, let's say, elementary school and then middle and high school?
Well, I think the most important thing we need to say is that clearly the best way to control, to open schools safely is to control COVID in the community, right? If we can bring community levels down, and when I mean down, I mean below 10 cases per 100,000 population, ideally even lower than that, 5 cases per 100,000 population, then you don't have to worry about these issues. When you have ongoing transmission, then it's a very different story. Then you have to worry about it. Then you have to say, hey, what are we going to do? Who is likely not to get sick, In general, younger kids are probably safer going back to school. I think about older kids, adolescents, high school, a little bit like I think of colleges, right? I mean, they're gonna get infected and they're gonna bring the infection home. So if I'm gonna do that, I'm going to make sure that those kids, and they're going to be, most of them are asymptomatic when they bring the infection home. So if I have at home, if I'm in a multi-generational household, or if on the weekend we're going to go see grandma or grandpa, I will make sure that adolescent doesn't go, or if they go, they're wearing a mask because they could be infected and they could be transmitting the disease. There was an interesting paper recently in PNAS and Procedures National Academy of Science that talked about this reduced development of COVID in children, and looking at potential sort of checkpoints, molecular checkpoints that can illuminate into the pathogenesis. And one of the things that is interesting in that paper is that children do appear to have less receptors for the virus in their respiratory epithelium. And that may be one of the reasons that is driving sort of a lower infections in children and a lower impact of disease in children. Understanding why children do better, I think, will be really critical in understanding what kind of treatments and preventions we need to do, because clearly there may be some protection from other coronavirus infections. There may be differences in their T-cell responses. So there are a couple of things that I think are real interesting in children that are very, clearly children and adults respond very differently to these viruses.
Right. Let's switch gears a little and talk about some drugs that exist out there. So how useful is the antiviral drug remdesivir for treating newly diagnosed COVID-19 patients?
Well, Dennis, I'll start by saying what I said before. All the studies that we've done thus far, all the results we have are in people that have severe COVID, that are in the hospital, that require oxygen, which only happen to be about 12% of people that get infected. So for the great majority of people that get infected, we still don't have anything. We don't have anything equivalent to a Tamiflu for influenza, a pill you can take. And that's where we need to go right now, because that's the great majority of people. Obviously, the research initially was to try to decrease mortality, and that's when remdesivir and other drugs come in. Remdesivir, I think, has shown clear benefit, but the benefit, I think, at best, Dennis, is modest. It shows a decrease in the time to improvement and maybe a signal of a decrease in mortality. But the reality is the mortality decrease in remdesivir is very minimal. And I think that remdesivir is one component. Like if I have somebody critically ill right now, who comes to the hospital, needs oxygen, remdesivir and dexamethasone are the two drugs that I have available that will optimally manage the patient at this point in time. But that treatment right now of remdesivir plus dexamethasone, I feel like the early years of HIV. We're giving, Bactrim and Zidovudine. We're way away from the drugs that we have nowadays, right? It's just the beginning. It's just, they're a little bit of a good job, but they're not doing what we need them to do.
Yeah, I agree. And it's an issue of timing. Each of those drugs probably has a place if you can time it properly, if you can hit the virus at an early stage. With remdesivir, that's fine, except you don't know about it. And the same is true
Well, not
with
only
dexamethasone.
not only that, Dennis, but remdesivir is IV, right? So even if you have somebody newly diagnosed, but they have mild disease, you're talking about putting an IV and giving them an IV for 5 to 7 days. So the treatments we have right now are really far from optimal from what we need to be.
Yeah, definitely. All right, let's try and look at another aspect.
And again, let me just say one thing in treatment. I really want to challenge you and others who work on drug development, because finding a drug like Tamiflu for influenza, something that we can give orally. I mean, a lot of people we give Tamiflu for influenza is not just because it decreases symptoms. It actually is because it decreases shedding. So if you can take people who had newly diagnosed COVID and who were not sick enough, but give them an oral medication that not only decreases their chance of getting sick, but decreases the viral shedding, you could actually impact transmission. So the treatment as prevention, I think could be applied to COVID if we had those drugs. And I think that's where the next frontier is. How do we find drugs that actually decrease transmission?
And hopefully our EIDD 2801 MK4488 is going to be the first of those really effective oral drugs.
Absolutely. I think that's going to be a really good drug to have.
Yeah. So a news article recently suggested that UK Prime Minister Boris Johnson will be resigning in the next 6 months due to complications from his previous COVID-19 infection. Whether or not that's true, it does raise the issue of long-term morbidities associated with COVID-19 infections. Can you tell us what's known about this at present?
Yeah, this is a very interesting area and something that I've been studying a lot recently because I had to prepare a talk for the National Academy of Sciences that put a committee on this. And it is fascinating to see that not everybody, that a lot of people who develop COVID, symptomatic COVID, not necessarily in the hospital, develop this long-term not feeling well. And I think we need to, part of the problem is we have more data. There are a couple of things here. Number one, when people go to the ICU, just because you're really ill, you know, we've known before COVID that if you were critically ill and you got out of the ICU, you took some time to recover, right? So we need to distinguish the severity of disease from just being really ill that takes you a long time to recover to the complications of COVID. Then we need to distinguish what some people call the post-acute COVID syndrome, which the Italians, for example, said that about 60% of patients that recovered from COVID 3 months after the disease, they were still having symptoms, and the major symptoms were fatigue and shortness of breath. But then you have the people beyond 3 months and what kind of side effects they have. And in that respect, we think about three places. We think about the brain, we think about the heart, and we think about the lungs. And we see people that have pulmonary changes, that have decreased diffusion capacity, that have some fibrosis. We think about the heart, people developing myocarditis, heart inflammation that can lead to heart failure. And then we think about the brain and, you know, people complaining of one or two things, either sort of an encephalopathy, people call it frequently the COVID fog or the COVID brain, or people having other side effects such as strokes and other complications from thromboembolic disease. So I think there are many things in here, and I think we need more research. But I think we need research that is really multidisciplinary. I think part of the problem we've had so far is sort of everybody's looking at their own area, but not looking at the comprehensive picture. And around many places around the country, we're seeing post-COVID clinics pop up. And those post-COVID clinics would be a good place to have this kind of research happening. It's interesting, there is a place that the UK investigators have found this place, have started this place that I would encourage people to look at. That it's a website that you can access through your smartphone, and it's called the COVID Symptom Study. And in this place, where people now, over 4 million people in the UK, in the US, and in Sweden have entered symptoms there, and about 10 to 15% of people, including some with mild cases, say they haven't recovered fully. They still continue to have symptoms more than 3 months after their disease. So I think we really need better definitions, we need better data, but I think this kind of population-based studies are going to give us a lot of the answers to those questions.
Yeah, on social media, these people are now called long haulers.
Yeah, long haulers, exactly.
And so there's enough of them out there to be given a name. And I agree that there's a lot to be learned. And I'm the wrong guy to make this presumption, but I think because, or I believe because the receptor, the ACE2 receptor that interacts with the virus is so widely distributed that depending, as you were alluding to earlier, depending on how much of this is present in various tissues and organs, you can get more or less damage from the virus interacting.
I think there's absolutely no doubt about that. I think that one thing we've learned very clearly is that this is not just a cold. This is not just a respiratory infection. This is really, in many patients, a systemic illness, and because of the ubiquity of the ACE2 receptor, you can have manifestations and damage in multiple organs.
So this is just a curiosity, but a woman in Quebec reportedly tested positive for 55 days, which is way beyond the normal course of this infection. So does this mean that some people can be infected for a very long time, or is there another explanation for this?
I think there's another explanation. The great majority, there's some really nice data now showing that people that have mild to moderate illness, after 10 days, they're no longer infectious, even though they may test positive. And people that have severe illness or critically ill may take a little longer, maybe in the order of about 20 days, 21 days. So in fact, CDC has changed its reliefs from isolation recommendations based on this. And they said, we no longer require people to have negative tests because in fact, the PCR test is so sensitive that you're testing for fragments of virus, but you're not testing for live virus. So the recommendation now from CDC is if you've been 10 days after your initial testing, you can no longer need to be in isolation because you are no longer infectious. If you've been critically ill in the hospital, we talk about 20 days.
So if SARS-CoV-2 is like other respiratory viruses, there's a reasonable chance that people could have more than one infection. Some scientists have suggested on subsequent infections, the immune system might mount quicker responses to SARS-CoV-2, leading to a maybe milder infection. If that's true, and this is an aspiration, SARS-CoV-2 might transition over time into a less daunting threat. Can you speculate about this for a little while?
So there's several things there that I think are fascinating. Number one, we're pretty sure nowadays that there is indeed some immunity to this virus post-infection. How long that immunity lasts, we don't know. There have been cases of reinfection, but they're few and far between. So there's probably is some degree of immunity. Now, we don't know if somebody has been infected and gets exposed to somebody again, do they indeed develop a mild disease or an asymptomatic infection again, just because of what you're saying? The other thing is we do know there's some cross-reactivity from other coronaviruses that may offer some protection. And the third thing is that there is the degree of protection you may have may indeed be related to the degree of disease you have may be related to the infected dose. In fact, and some people say that maybe we're seeing more asymptomatic and mildly symptomatic cases now than we did before, because when you're wearing a mask, or when I'm wearing a mask, let's suppose I'm infected, I'm wearing a mask, and I infect you because you're not wearing a mask, and I'm wearing a mask, but the dose of virus I give you is much lower. So the dose may be lower, and that lower dose may be driving a lower infection. So I think the immune system, the interaction of the host and the pathogen is very different depending on the infective dose and the immune status of the host.
Yeah. So I think this idea of the dose of virus that you receive and the density of receptors that the virus encounters probably could account for many of the observations that are being made right now.
And in fact, for example, we know that men tend to get more sick than women, and it probably is because men have a greater percentage of ACE2 receptors in their upper respiratory tract than women. So they may be getting more virus.
Interesting. So let's chat a little about vaccines. Deploying vaccines to people in the US and around the world will test and strain distribution networks. It'll test the public trust, and it'll definitely require global cooperation. Some believe it will take months, others years to reach enough people to make the world safe. So for those who do manage to get one of the vaccines being developed, how long do you think it will take for them to develop some level of immunity?
I mean, I think the vaccine story is amazing, right? Because we went from doing a sequence on a virus to getting a vaccine into humans in 62 days. I mean, that was just unbelievable. That has never happened. We are now in phase 3 trials in several vaccines. And that, again, is just incredible how quickly that is going. So I like the way the vaccine has moved, the vaccine research and world has moved in this disease so quickly. I think we all need to be proud of. Having said that, I'm also a realist, and I see several things. Number one, we are testing vaccines in new technologies and new platforms of which we've never approved a vaccine for. So we're almost like, developing new airplanes, but they happen to be rockets, right? And we've never tried them. They're really fast, but again, we are, if this works and the technology works, it's going to change this vaccine world, but there's no track record of an mRNA vaccine or an antivirus vaccine going all the way to approval and being used in humans. And that, I think, is one of the big challenges, right? I mean, we're in totally unknown territory. Number two, developing vaccines for respiratory viruses is notoriously difficult. And as I was saying, in influenza, we get vaccines with 40 to 60% efficacy. Here, the FDA has said, we're looking for a vaccine for 50% efficacy. So it's not going to be a vaccine as good as the HPV vaccine, which is 100% effective, or the measles vaccine. It's going to be a 50% efficacious vaccine. It's going to be an okay vaccine, but not a perfect vaccine. It's going to be one of those that you say, it gives you some protection, but it doesn't protect you 100%. And then number three is what you're talking about, right? The distribution, the deployment is going to be an enormous challenge. And it's going to be a challenge, number one, because some of these vaccines require refrigeration. Some of them require even -70 refrigerator. And so we don't have the cold chain capacity right now. I think about some refrigerator vaccines, the Zostavax vaccine, which is a wonderful vaccine, the Zoster vaccine, has had a very little uptake, in great part because it needs it's frozen, and you need to unfreeze it before you give it to somebody. So planning of administering that vaccine in clinic, it's very complicated from the pharmacy. Well, the same thing is going to happen with this vaccine. So there is not it's not going to be easy to do. It's not like you can do just, vaccine runs in the community when a vaccine that needs a -70, unless you happen to go around with your, nitrogen freezer with you, and then you have to unfreeze it and all that stuff. Then number two is getting it out there if we're going to, we think about herd immunity. If we're going to have 60 to 70% of the population immune between natural infection and vaccine, let's suppose with natural infection, we have right now 20% of the population immune. We still need 40% of the population immune through the vaccine. Well, to get 40% of the population immune for the vaccine that has 50% efficacy, you got to vaccinate 80% of the population. So, it's going to take us some time to get there. It's not going to be, and that's why I tell people, when people say, oh, we got to do all these things until we have a vaccine. No, once we have a vaccine, we got to apply, we have to deploy, we have to get acceptability of that vaccine. It's going to take time. It's not going to be straightforward. I think it's going to be not an insurmountable challenge, but it's not going to be a small challenge. And I think all of us are really worried about, how quickly can this possibly be done in a way that is safe and effective.
Absolutely. So while we're talking about vaccines, people hear a lot about antibodies and how their levels correlate with immunity. But there's also another kind of immune response, and that's ones that involve memory T cells. And what role will memory T cell immunity play in our overall susceptibility to COVID-19?
I think that memory T cells are going to be critically important in the protection against COVID-19. And in fact, a better memory T cell may be one of the reasons why children actually do better, but memory T cells are critically important in the protection against COVID-19. And I think we have not studied them enough. And I think the people that do our cellular immunology are probably very excited about it right now, because there may be ways through immune manipulation and immune stimulation that we can get a better T cell response against some of these pathogens.
Good. Do you think people will have to take at least one booster shot with these vaccines that are being developed?
The current vaccines that we're using are being tested by giving a a dose and then a booster shot of months later. So it's 2-dose vaccine. So unless something changes, the vaccine that is going to be approved is going to be a 2-dose vaccine. So I think that's going to be another challenge, absolutely.
Yeah, and and I've heard even speculation that there could, in certain cases, even be a third booster down the road.
You may need annual boosting, right? You may need,
right.
depending. I mean, I think this virus is going to become part of our respiratory virus population. I mean, I think about, H1N1. H1N1 produced a pandemic in 2009, and it's still circulating around. It's still incorporated into the vaccine for influenza we normally take.
Yeah, well, since you mentioned influenza, what type of extra problems can we expect with our ability to treat COVID-19 patients now that the flu season is getting ready to begin?
I think all of us are really worried that, COVID and flu are going to coincide and give us a big problem. So several things are happening. Number one, the diagnostic companies are developing diagnostic platforms that allow you to test for both viruses at the same time, so you don't have to do 2 tests, but you can do 1 test. And number two, we are deploying antivirals and vaccine in an effective way. Having said that, I also like to be an optimist, and I think if people get vaccinated, but most importantly, if people continue using masks and social distancing and washing their hands, there is a potential that we may not have a flu season. And that's indeed what happened in the Southern Hemisphere. In Australia, New Zealand, Chile, Argentina, that are just finishing their winter season, the flu season this year was almost unknown. It went away. And it went away because all the measures that we're taking for COVID, because COVID is way more infectious than the flu. So doing those things really cut down on the amount of flu we have. So maybe one lesson out of this is after we get done with COVID, we'll start asking people to wear masks during flu season, because in fact, we can actually get rid of the flu if we do that.
Yeah. And, I was looking over a little history the other day, and I was reminded that the polio vaccine, it took 25 years to actually rid polio from the population. And do you think, especially based on what you were saying about H1N1, do you think it's going to be a long time before we see the last of COVID-19?
No, I think so. I think COVID is going to become sort of part of the respiratory pathogens. Hopefully, it's going to move from being a pandemic virus to an endemic virus. I mean, we'll see it, it'll be here, we'll go up and down like influenza, but it won't be causing the amount of disease and death that it's currently causing. I mean, right now we're exposed to a new virus with naive immune systems. I think as we get more experience with the virus and better immune systems, we'll do better.
Let's spend a little time on issues relating to testing for the virus. Problems with testing availability, accuracy, readout times have significantly contributed to the spread of the virus. Clearly, if someone has to wait 8 to 10 days to get the results of a highly accurate COVID-19 test like PCR, the test is useless. On the other hand, some antibody tests give quick readouts, but they also can give pretty high amounts of false positives and false negatives. Given these facts, what is the best strategy we should use for testing?
When I think about testing, Dennis, I think about, well, first of all, companies are really developing and individuals are developing an incredible array of testing. And I think, if you look at the FDA website, I do every day, there's EUA authorizations for new tests almost every, 3 or 5 every week of different tests for COVID. Number one is that, there's a lot of tests out there, so it's a little bit of the wild, wild west. But I think about testing as diagnostic testing and surveillance testing, right? When I have somebody who's sick and I need to test them, they come to the clinic, they're not feeling well, I need to test them. I need a test like a PCR. I need a test that can give me a lot of accuracy and I can make a diagnosis. But when I think about surveillance, and I think about surveillance, for example, kids are returning to Emory and we need to test them all. Or, or people are going to return to an office and they want to test everybody. then PCR, the diagnostic test, may not be the test we want. We can use a test that has lower sensitivity, but it's cheaper and a rapid turnaround. So there, an antigen test may be better. Something like you can do a rapid test, that you can do an antigen test, not a PCR. And yes, it will give you some false negatives, but also give you some false positives. But the false positives, you then go ahead and do a PCR to confirm, right? But the false negatives, if you test frequent enough, you're going to take care of the false negative issue. And then the antibody test still needs to find its niche. And the antibody test, a lot of these tests don't become positive until about 10 to 14 days after infection. So they offer an opportunity to do surveillance testing for sure. If I want to be out in the community and see, okay, what percentage of people in Decatur have been infected, I can do a study and find that out. But it's not going to be something that I can use for diagnosis unless somebody comes to the hospital, comes to the clinic, let's say 2 weeks after infection. And maybe I'm seeing somebody in the ICU with ARDS and very sick and intubated, and I do a respiratory swab for PCR and they're negative because the virus is no longer there. Now they have a lot of the immune response to the virus that is causing them to be sick. That's somebody I will test an antibody test, because if the antibody test is positive, I'm going to say, okay, this is probably a consequence of COVID-19, but it doesn't have a lot of use in routine diagnostic testing at this point in time. I do think that in the future, there are going to be tests. There's a test that FDA approved recently called the Binax Now, produced by Abbott. And there's going to be other tests like that one that are lateral flow tests that are point of care that can be done outside the lab. Abbott said that the Binax Now is going to be available for $5 a test that you could potentially do at home, right? And just, as you're let's suppose you're having 30 guests come to your house, you can just test everybody, here's your little test, and before you come into the party, just test yourself. And I think that's going to be part of what happens in the future as we think about using the test in a more effective way.
Yeah. What do you think about the efforts to test sewage to quickly identify potential SARS-CoV-2 hotspots?
That's really a very interesting approach, and some places are doing it, getting some good results. Looking at sewage coming out of fraternity houses, for example, or buildings. I think it's a very good way for public health to find the disease, right? I think it's a very useful way for public health to find where the disease is moving and move in there before you start getting symptoms. And again, what we want to do here is move in before symptoms. I mean, I think what we're not doing a good job is going in and we're not doing a good job of preventing outbreaks. I think cases are going to happen. What we have to prevent is outbreaks. We have to prevent massive amount of cases. If we have a case here and there, I think we can handle that.
Yeah. And one of my concerns is our general insufficient infrastructure to do all the things that we've talked about. In addition to the obvious taking care of patients, we have testing, distribution of vaccines. Do we have sufficient healthcare workers, protective gear, syringes, data monitoring system, manufacturing capability, transportation, storage, all of those things? Do we have enough to actually pull this off?
Well, the challenge is what's enough, right? When I think about PPE, if we have a huge surge, we're not going to have enough. For the current number of cases we have enough. But the issue is, can we keep the cases there? And the same thing happens with testing. When you were saying testing was getting behind and was taking 10 to 14 days, in great part it was because we had a surge in cases and all of a sudden we had to do so many tests. So you always build the infrastructure for what you need, but you can't predict the future, right? If all of a sudden right now you had a huge surge, I mean, I'm thinking about colleagues in India, for example, and how India's having close to 100,000 new cases per day. There's no way to keep up. There's no way to have enough PPE or testing or anything to get over that. I mean, they really are in a very difficult situation. The way cases are right now in New York City, for example, in which they're having less than 3 cases per 100,000 population, they have plenty of testing, plenty of PPE, they're doing just fine. So Part of the challenge that we've had with not having a national strategy in our country is that you wish you could move those things around, right? New York has too much. We need to move it to North Dakota because they're having a problem right now. And the ability to do that logistics, I think, would have been a really key role of the federal government in this pandemic, or to say, you know, North Dakota really needs testing right now. We're going to take those swabs and send them to Massachusetts where they have too much testing capability. And that logistics is really what you need to see happen. The reality is that we are in a point in this pandemic where we're planning for the future is incredibly hard. And again, I think what we need to rely on and what we need to encourage is what always gets us out of trouble, which is innovation, right? Is discovery and innovation. And I think there are a couple of things that have worked really well in this pandemic, I think. And one of them is scientific discovery, is research has worked incredibly well and has given us vaccines and treatments and other things. So we need discovery and innovation to help us get out of this. And I've seen a lot of innovation happen in PPE, for example. I've seen people come up with face shields and with all sorts of things that we never had any idea before. And I think we need investment in better masks, in better face shields, and better PPE that people can then use in a more effective way. And so I think it's not just using what we have, but doing more of what we need.
So let's even expand the scope of that. So we know that COVID-19 has had a devastating effect on the economies of most of the world's countries. A recent estimate by the UN suggests that in 2020, hunger may kill more people than COVID-19. This isn't just happening in low-income countries. In Queens, New York, the lines snaking around a food bank have been up to 8 hours long as people wait for a box of supplies. Ironically, at the same time, farmers in California are plowing over their lettuce crops and fruit is rotting on the trees in Washington.
Yeah, and they were killing pigs.
Yes, that's right. They're slaughtering pigs. And so this is those logistics and supply chain issues now on a macro scale. And are we being unrealistic to believe that SARS-CoV-2 vaccine will be the magic bullet to cure all our economic woes?
No, I don't think so. And again, but maybe SARS-CoV is the opportunity to rethink logistics, right? And to rethink how do we manage those kinds of things so we don't have the issues that exactly you're talking about. We need to have a very different way of thinking about these issues and these problems. And I hope that this epidemic gives us the opportunity to actually move into a different level, you know, the same way we moved into a different way in communications with cell phones, right? How we moved in our generation from, I mean, you and I grew when you had a rotary dial phone, right? To get to somebody, or even, I still remember, you know, I was very young, but I still remember in some places having switchboards, right? That people would, you know, at a business, somebody got a switchboard where somebody would connect the calls. And now we're in cell phones and we're in internet and we are connecting and through Zoom in different ways. So I'm hoping that SARS-CoV is an opportunity actually to do our revolution in the way we provide healthcare, but also in the way we provide, you know, access to food, access to many other, you know, goods. We are a society that has a lot of wealth and a lot of poverty. And how can we balance that in a better way? How can we have the production that is happening that is causing people to throw food away benefit for those that are actually dying of hunger? How can we make sure that we can have a better distribution of the many things that we are producing on a day-to-day basis?
Well, in addition to threats to our food supply, increases in arthropod vector spread and urbanization of the world's population increases the likelihood that future pandemics will be harder to control. Arguably, the CDC, the FDA, and the WHO all have failed badly at dealing with SARS-CoV-2. As a practicing infectious disease physician, do you think that some significant changes in these agencies can be made that will adequately prepare us for future pandemics? Or do we have to create a new global infrastructure that can enable us to respond rapidly and effectively to these threats?
I mean, I think there are two issues here. These agencies have failed us badly, but they have failed us badly in great part because we have underinvested in public health. So if we simply did not have the agencies we needed to respond to the threat that we had. So it's a little bit like saying, you know, I went to compete at the Indianapolis, 500, and my BW bug failed me badly. Well, it was not the right car for that kind of race, right? You didn't have the right equipment to be where you were. Now, this is in a way what has happened. We have underinvested in public health. And Bill Foege says something that is absolutely true. And he says, nobody's going to thank you for a disease they didn't get. So we don't value public health, and maybe something that can happen out of this is we can value public health and have, the question is not do we need different agencies, but what kind of investment do we need to have, and what kind of resources do we need? For example, here in the state of Georgia and many states, initially when we were testing for SARS-CoV, part of the problem with testing is that the state laboratories did not have enough equipment, they did not have enough people. They were decimated for years and years of underfunding. So we need to be ready to do the kind of stuff we need to do and surge rapidly. And I think reevaluating the true investment in public health, I think is going to be very important. The second thing is, I think is going to be to really rethink the global governance and architecture, right? And how do we ensure better cooperation? We were seeing this happening in China, and we were all watching it, and we were all reading about it, and somehow we thought they were going to be controlled by the Chinese, and the Chinese thought they were going to control it by themselves. And when many times when the WHO and the US and others offered to go help the Chinese said, no, we're fine. And they weren't fine. And it's clear that they weren't fine. So international collaboration and cooperation needed to happen so much earlier. WHO took a long time declaring this a public health emergency of international concern. I mean, a lot of things just didn't happen the right way. And clearly understanding this is going to allow us to do a better job later. But I hope that one of the most important things we do is, I think we need to get rid a little bit of our nationalistic view and saying, oh, I know how to do it right. We really need a true recognition of all the things we all did wrong and start from there and say, okay, what were the mistakes across the way that allowed this to happen the way it has? I will say honestly myself, I didn't think this was going to be this severe when I started seeing the first cases happening in China or even in Europe, right? I thought we were going to be just fine, and then it hit New York like a tornado, and we started seeing a big problem. And by that point in time, I felt like saying, gee, shouldn't we have thought about this? Shouldn't we have said, with the amount of flights coming to New York and to the West Coast, this is going to hit us big time because this virus is going to be here before we know it. And that was indeed the case. But somehow we didn't do it. So I think we also need to rethink about how do we do surveillance? How do we monitor for these diseases? And the last thing, Dennis, is I think we need to really take climate change seriously, because a lot of these diseases is happening because of climate change. A lot of these things are happening because our interaction with animals that you were talking about. So looking at those, live animal markets, looking at climate change, looking at beyond health is going to be really important.
Very good. Well, while I have you here, I think I want to ask one last question, which is a little tangential, but I think for our audience, it might be instructive. So you're one of the top HIV clinicians in the world, and we've made such apparently good progress in developing COVID-19 vaccines. You talked about 7 months, and can you help everyone understand why we haven't been able to create a viable vaccine for HIV, which we've known about for almost 4 decades?
I think, Dennis, there are many reasons. Number one is they're two very different viruses. But number two is HIV in general, except for few cases, there's nobody that has been able to. Nobody is able to control the disease, and more importantly, nobody that we know has been infected and then recovered. So we don't know what the immune response to the virus is. We don't know what the immune system needs to do to control the virus. And what we learn over time is that the immune system actually does a good job controlling the virus, but then the virus mutates and is no longer controlled, and the immune system does, and the virus doesn't. So it's almost like every time the immune system produces something to control the virus changes and outsmarts the immune system until eventually the immune system essentially dies of exhaustion, and then the virus, kills the individual. That's basically what happens. So part of the problem is that HIV is really a very difficult creature, right? And you would have to have a vaccine that controls the virus not one time but multiple times. And that, I think, is one of the biggest challenges, is how do you train the immune system to do that? Because the immune system in a way is doing that, but is not doing it effectively. So I think that a vaccine for HIV, honestly, is a huge scientific challenge that is still trying to be understood. I think we have a lot of smart people working on it. I still yet to see something that says, looks like the exit. My hope is that, before I retire, we will have an HIV vaccine. But I tell you, I'll turn it back to you. The development of therapeutics and what you and others have done in developing drugs for HIV, in my mind, has been nothing but amazing. We have gone, in my lifetime, from seeing people die of this disease to see people live healthy, productive lives and have the disease and the infection control in a way that they don't not only live normal lives, but they no longer transmit to others. They no longer infect others. And that, to me, is just incredible. And what drugs have done to control HIV has been nothing but amazing. So I think we need to think about, again, I mentioned it earlier, treatment as prevention. How can we use treatment as a way to find prevention and stop thinking about, vaccines are prevention, drugs are treatment. In fact, they're intimately linked, and really drugs and vaccines together work for treatment and for prevention.
I think that's a great way to end this session. And I just want to thank you very much for your willingness to participate.
Delighted to be with you, Dennis. This is always a pleasure talking to you.
All right. Take care.
Thank you.